Hello and evening, everyone. It is the 19th of January, 2021, and today we are doing a special broadcast on dermatology and its relationship during COVID-19. I've got two expert guests, Julia Wheeler and Lucy Moorhead, who have dedicated their evening to talk about this topic. Evening, everyone.
Evening.
Good evening.
Fantastic. So, without further ado, let's crack on. So, I think the key thing for the audience to be aware of is that this is an educational event. Of course, Julia and Lucy will give their expertise, but don't hold this as gospel, because everyone is responsible for their own care. So, everyone, if you have any questions or concerns, please do liaise with your dermatologist if you're involved within that service, or liaise with your GP. But certainly, I think Lucy and Julia will share their vast experience on this area. So I'm going to start off with Lucy. Lucy is a nurse consultant in inflammatory skin disease at St. John's Institute in Dermatology at Guy's and St. Thomas's NHS Foundation Trust. She has a background in dermatology research and clinical trials, and has been awarded BA Honours in nursing. She's also a trustee for the British Dermatological Nursing Group, which is how I came across both Lucy and Julia. And she's got a host of publications, as well as Psoriasis Nurse of the Year and Nightingale Nurse Award in the previous year. So thank you again, Lucy.
Thank you.
So I will let you run the show. So over to you.
Brilliant. Thank you very much for asking me to speak tonight. I'm going to share my experiences over the next 15 to 20 minutes on how we've optimised a remote dermatological assessment during the COVID-19 pandemic. So next slide, thank you. So I'll just introduce you first to dermatology and provide an overview of our medical dermatology services, and briefly touch on the additional input that's required to optimise remote dermatological assessment, and signpost to some what I found to be useful sources of information, and then just end with some top tips. So I think virtual clinics were not a new idea, and that pre 2020 and pre-COVID, we'd already recognised that we had an increase in demand on all of our services across the board, particularly in dermatology. I've been working in dermatology for over 20 years now, and when I first started, we had hospital ward. We had a 32-bedded hospital ward with psoriasis patients who would come in for lengths of stays up to 6 weeks and have topical treatments applied. And a lot of the systemic treatments that we established patients on required quite intense monitoring. And really, there's been a revolution in treatments over the last 20 years. And we now have a cohort of patients who are well established on biologics, which require less monitoring than perhaps some of our other treatments. Aside from that, the Royal College of Physicians in 2018 acknowledged that outpatient care with its current model was not sustainable, and it was also in the NHS long-term plan to reduce face-to-face appointments by a third. And I do remember reading that at the time and thinking how ambitious that was now, and obviously that seems very strange in light of everything that's happened over the last year. So next slide. So I think just before I begin, I work in a very large dermatology centre. In many hospitals, medical and dermatology and skin cancer services are combined, but for us they are very different, and so the examples I'll be talking about tonight are really related to medical dermatology. I think there's an assumption that dermatology is ideally placed for remote and virtual consultations because we have the benefit of normally being able to see on our patients what we're treating, which other specialities don't, but it's sometimes not that clear cut. An audit in December 2019 identified that already 30% of patients were offered remote consultations across the board in dermatology. So there has been an element of remote consultations for a while, but with the impact of the pandemic in March 2020, it meant that we really had to sort of sit down and rapidly redesign our services. We'd already, as I'd mentioned, we'd recognised that our patient cohort had changed over the last 5 to 10 years, and I'd been working as part of a multidisciplinary team with a care design team, looking at a new model for our well-established patients on biologic treatments, whereby we were going to replace some of our face-to-face visits with virtual consultations. And we were discussing whether the virtual consultations might even take the shape of a platform whereby patients would answer a series of text messages. And we were in the sort of early stages. We were piloting different methods. And then obviously March 2020, we had to sit down and actually rapidly redesign our services. And so the model we came up with was similar to the proposed model, but there were slight differences. So I think if you just click onto the new model, please. Brilliant, thanks. So basically what we aimed to do was to see our patients twice within a year, and we tried to do sort of combine some visits. So if a decision was made to start the treatment, we would try to arrange a nurse initiation at that point. Obviously, in a way, in March 2020, it was perhaps easier to make the decision to switch patients to a virtual consultation, because we had the benefit of seeing or hopefully having seen all our patients within the last 6 months. I have to say, this time round, we're back in the same situation where we are running virtual appointments unless it's clinically necessary to bring the patient to hospital. It's been a bit of a tougher call. And actually, we're in discussion at the moment that for some of our patients, again, if they are well established, on a per patient basis and discussing with patients the risks and benefits of the decision, but that we might actually see for some patients only issue their prescription on the basis that we've seen them in the last 18 months. So that's a huge change, but I think ideally going forward we will be looking to hopefully review our patients on a yearly basis. And one of the sort of initiatives what we have done is, in order to reassure our patients, is develop a sort of a contact card whereby patients feels secure that they can actually get in contact with us if they have any clinical queries or questions. And this is just an example of the platform we developed. So the idea is then obviously it's only suitable for patients with mobile phones, but patients will receive a message which invites them to complete the assessment. And I think if you go to they then just have to enter some brief demographic details so they log into the portal, and they're then invited to complete sort of PROMs, so a patient global assessment and a DLQI, which I'll go into in the next couple of slides. And then they're asked questions, so they have to confirm the treatment that they're on, answer a couple of questions, and they submit the form. And the benefit for us, so we're not at the moment doing virtual consultations, we're doing telephone consultations, but the benefit for us is that we can actually then see all this information before we call the patient. And that's really useful because it really helps us focus the consultation, so we can see actually, is the patient reporting that their skin is currently severe, and therefore they're going to need some kind of triaging and perhaps bringing into the hospital, or do the patient feel actually that everything's stable and they can continue on their treatment. And this again just shows you the information that we are collecting. So that's sort of actually just confirming the biologic that they're on, making sure that they're injecting it appropriately or taking their medicine appropriately at the correct time point, completing the DLQI, completing a global assessment, and then just some other questions as well. And I said we've really found it has aided our consultations by telephone, so I'd recommend it. I don't know, I can't see this very well, but actually the Dermatology Life Quality Index is a widely used tool in dermatology. It's suitable for all dermatological conditions, and it really captures the impact of a patient's dermatology condition on their day-to-day life for the week preceding the time point that the questionnaire is completed. And in a way, this is as valuable as the patient global assessment, because it kind of gives you an insight into the impact of the skin disease on the patient's day-to-day life. So this is fed into our patient portal. So again, before we do the telephone consultation, we can see the answers to this questionnaire. There's a really good website which has different translations and a different questionnaire for children as well in different age ranges. But it's also important to note that this questionnaire does not measure depression and anxiety. So for any patients that we have concerns or we want to screen for depression and anxiety, we would use the NICE validated tools, the GAD-7 and the PHQ-9. Anyone who works in psoriasis is familiar with the Psoriasis Area and Severity Index. This is a tool by which we can grade the severity of someone's psoriasis, and the benefits, or the really good thing about the PASI score is that it actually looks at psoriasis on different parts of the body. Psoriasis can appear differently, say in the groin and the head, to how it looks on the arms or the legs, and allows you to grade how red, how thick, and how scaly the psoriasis plaque is, and the area affected by psoriasis. And we do this routinely in all our clinic appointments. And obviously now with virtual clinics, we're just relying on a global scale, on a global evaluation scale. But what we have been able to utilize for patients for remote assessments is something called the SAPASI. So that's the self-administered PASI, which I think is on the next slide. And that's this one here. And so what we do is we invite patients to draw on the body map. So obviously they have to have access to technology, so they have to be able to receive the document and print it out. They can then draw on the document areas affected by psoriasis. They then complete the visual analog scale on the right by choosing a representative or a typical plaque of psoriasis and then scoring its redness, thickness and scale. The one, psoriasis can present as large plaques on the body or very small plaques. This SAPASI is definitely beneficial for patients with larger plaques, because what you often find if people have lots of small plaques, the temptation is to just score out the whole body, which can make it different to evaluate the area. But then when you receive this document, and again you can ask patients to take photographs and then email it or text it back via their phone. When they send it back in, you measure the score and then use that to input. And it might look a bit complicated, but it's actually very easy to use. And we found that that's correlated quite accurately with patients' PASI scores when they come in. And the reference for anyone who's interested in knowing more is at the bottom of the screen. We obviously invite patients to send in photographs. For that, we do have a secure nhs.net email. We have a very large cohort of patients. So for instance, in our biologic clinic, I think we have sort of 1,700 patients on biologics, and we have sort of 600 on systemics. And this nhs.net email address serves patients in all of our tertiary clinics as well as our general derm clinics as well. So we do ask patients to restrict to 4 photographs purely for size. Any patients who are asked to send in photographs, we do ask them to provide their full name, hospital number and a date of birth, and we also ask them to provide written consent in the body of the email as well, so that we can upload the photographs to our electronic patient record. On site, we're lucky, we do have a medical photography department, but if that's not practical or possible, we can use a Pando app as well. And I definitely recommend, if you're working in an area where photographs might be useful, it's worth checking whether you can use Pando. It's an app whereby you can take photographs and send them in. One of the biggest problems we've had with remote consultations is actually obtaining blood monitoring. We are trying to restrict blood monitoring and really looking at whether it is necessary. So again, going back to what I said earlier, there are some patients that we're now saying could possibly need bloods only once in every 18 months, but ideally it's every year. For some of our patients, they can obviously come to the hospital, and patients who come to our hospital at the moment, we send them a letter so that they can obtain entry, and then we have a directorate blood room, and patients can call up, and so when they get to the department, their blood labels are all ready and they can be in and out quite quickly, and then we can obviously then track the results. For patients who do not live near the hospital, and I think over 50% of our patients in tertiary clinics are not within a sort of a 10-mile geographical area of the hospital. We have been asking GPs and primary care to take blood tests and send us the results, and that has been a bit of a logistical issue. Firstly, I think our letter wasn't good enough. So the letter you can see here on this screen, we've actually improved. We now sign it from a named clinician, and we actually make it explicit in the text of the letter that we're not asking anyone else to take responsibility for the monitoring. We're just asking for the blood test to be facilitated. And then we're now asking our administrative staff to help support the ordering clinician. Initially, during the first lockdown, we had our clinical nurse specialist team tracking the results and signposting abnormal results to the respective clinician, but our clinical nurse specialist team are currently redeployed, or the majority of them are, so that's not possible. Another issue has been actually identifying patients not attending for bloods quick enough. And again, we found that was a multitude of reasons. Some people were anticipating being invited by their GP. So for patients what we're trying to do now is in the consultation that we make it explicit that we would like the patient to contact their GP and arrange for the blood tests and make an appointment for the blood tests and then send them a copy of the letter as well. We've also found that by doing virtual appointments, we have had an influx of clinical queries. The clinical queries have varied throughout the pandemic. That was the photos I was very excited because that was the first day I had a headset, which was quite a treat. And what we decided in our department is we're quite lucky. We've got 3 senior nurses who are grade 8A and above, and we decided that they were best placed to answer the phone calls because we're all prescribers. We had the clinical expertise. We could prescribe if interim prescriptions were needed, and we also had the kind of logistical information in terms of patients who were needed to shield or patients who weren't able how to access delivery slots, etc. We worked on a rota, and it was actually, I think it was quite eye-opening those first couple of weeks back in March, whereby we had people calling us who'd been unable to speak to anybody in person, had been unable to speak to anybody in person about their particular clinical circumstances. We also had people who were quite angry, who hadn't quite realised that the drug that they were on was an immunosuppressant. In dermatology, some of our patients who were on immunosuppressants, if they were otherwise well, were not asked to shield, but were asked to obviously be very stringent with social distancing, etc. And some people were confused because they'd heard Boris Johnson say that anybody on an immunosuppressant had to shield. So it's just explaining clinical risk, and also vice versa. We have people who didn't want to shield but had been asked to shield, and people who were unable to obtain food. And today's phone calls have been very much around the vaccine. Either people haven't been contacted for the vaccine, or they'd rather not have the Pfizer one because it's associated with allergic reaction. So again, the situation has been very fluid. We are still covering the phone line with any of the nurses that are remaining, and we've also had some of our junior doctors have very kindly been helping as well with the phone line. I think as nurses, we've always, in my practice, I've always had a special interest in caring for vulnerable patients and making sure that they can access care in an equitable way. This definition is from the Royal College of Nursing, and it's a very familiar one in terms of what defines a vulnerable patient, and I don't think there's anything new there. And pre-COVID, we had the facility to refer patients to homeless units or access our vulnerable adults specialists or learning difficulties at CNS as well. But what I've noticed is actually since the COVID pandemic, that maybe the definition of vulnerable patients has somewhat changed. And I think now, sorry, just the next slide. That I think now actually, if patients, their first language is not English, and they don't understand that they're going to have a virtual phone call, or they're not able to communicate with the person who's contacting them, if people don't have access to smart technology, it can be difficult for them to be represented in our current patient pathways. And what we're trying to do is really sort of be proactive in scanning our clinic lists. And if we spot that any patients are there who perhaps are not suitable for virtual consults, that they are contacted and other arrangements made. Or that if a patient is on a list and they don't answer the phone, that actually we look a little bit deeper into their circumstances to see, is it because they're busy, or is it actually there might be other reasons for them not being able to answer the phone. We've also had a number of patients who's not been able to access their support services, and patients with learning difficulties and mental health needs, and actually not having that routine and not having that access to support, we have noticed has impacted in the way that patients access medication, and in some cases has resulted in deterioration of their dermatological condition. And obviously, I mean, across the board, we've seen the mental health impacts of COVID as well. Two examples that I came across, sorry, were that, I had a 90-year-old lady sort of who had listened to our answer phone message that I had recorded and actually gone to great lengths to record to try and make it clear, but couldn't navigate to the portal whereby you could book a clinical nurse specialist phone appointment. And actually, when I spoke to her, it made complete sense that that this service is only useful if to certain groups really within society. So again, what we've done there is we've made sure that, as well as being able to navigate to a portal where you can book a phone consultation, there is also the ability to leave a message so that somebody can book a phone consultation or call you back and clarify clarify the reason why you're calling. And again, particularly in dermatology, we have a lot of I have not a lot, but I have a group of patients who have stopped their immunosuppressants. They don't want to take immunosuppressants for just a skin condition. This particular patient does not want to come to hospital because she's worried with regards to contracting COVID, and she's a carer for her 84-year-old husband who's got cardiac issues. But she is sending us photos regularly, and we're trying to optimize her treatment with topicals. But actually, she was well controlled on methotrexate prior to the pandemic and really needs an immunosuppressant. And I'm still sort of struggling and trying to work out the best ways of really caring for patients in these situations. So yeah, I think it's just about making sure that any pathways we're introducing in these times, that we are ensuring that all of our patients are represented in our pathways. I think that nurses are kind of our clinical nurse specialists, etc., are sort of well placed to kind of track patients and provide continuity of care with virtual consultations. As I said, I think it's important to ensure that you have a rigorous process by which you can identify and track patients that you can't contact or who do not attend. And that, for me, it's helpful that I know that if I do start a virtual consultation with a patient and it becomes apparent that the virtual consultation is either not suitable or for the patient, or they need a face-to-face, then I have the ability to book them into a face-to-face appointment, and really within a week, which is great. And then the other thing, in terms of making sure that any relevant agencies are CC'd into all of our documentation as well, just to kind of provide that loop in a time when perhaps patients aren't seeing other healthcare professionals so easily. These are just some of the resources that I found that I've been quite useful. This is produced by Bart's. It's a pictorial guide to video consulting. It takes 5 minutes literally to read through it, but it's quite a useful one. And I hope that soon we'll be able to offer video consulting in our department. And the NHS obviously released guidance in March for remote consultations. There is one coming out soon for dermatology, and which is titled Setting Up Remote Consultation Services for People with Skin Conditions. The British Association of Dermatologists has fed into it, and Dr. Julia Schofield, as well, who's a kind of prominent dermatologist, has been leading on this. And it was good because I think I've had a look at the draft document for this, and what's been useful is it's aligned to our patient models, i.e. that within medical dermatology, remote consultations aren't really suitable for new patient consultations. They really should be done face to face, and that if you are seeing a patient where you need buy-in, so initiating a new treatment or it's a pivotal point in their patient pathway, then again, face-to-face appointments are more suitable than virtual, but that's definitely one to look out for in the future. The British Association of Dermatologists, just mentioned them, having a really brilliant resource page whereby they run through various guidance for different dermatological conditions. One in particular that was useful to us was for isotretinoin monitoring. Obviously, a lot of patients had isotretinoin stopped at the start of the pandemic, and a lot of patients who are on isotretinoin, obviously there's teratogenicity concerns, so they are put onto a pregnancy prevention program. And what the British Association of Dermatologists remote consultation guidance allowed clinicians to do was actually maintain patients on Roaccutane if it was appropriate, and they could perform pregnancy tests at home and email them in with evidence of the date. So be it a newspaper, for those few who still receive a newspaper, or indeed just taking a screenshot of something on the internet with the date on it, thereby ensuring that the patient was not pregnant, and then a prescription could be issued to a local pharmacy. And the other thing that the British Association of Dermatologists website contains is information of all the dermatology registries that are available. So there's ones for eczema, alopecia, and HS. The one that I'm predominantly involved in is the psoriasis one. So there is So Protect, whereby it's asked that any patient who has psoriasis and a confirmed or diagnosis of COVID is entered into the database by a healthcare professional. And I would recommend anybody having a quick look at this website. It takes 5 to 10 minutes to complete the data entry form, and you don't need to set up an account or remember a password. And then it's then submitted. And I think they've got over, I think it's 878 cases at the moment. I entered one today, and I'm pretty sure that was the number that came back to for me. And also for patients, there's So Protect Me as well, but they can just sign up, and they don't need to have COVID to do that. They just need to have psoriasis. Another form of good site of information is the UCL Partners one. Again, that's got loads of resources, toolkits, templates as well. So if anybody is thinking about setting up any remote consultations of any type, I would recommend looking at this. And then also, this is another one as well, just a final one. So this is a primary care research journal, and again, it's got information on video consultations, and I think signposts back to the BART's website as well, but worth having a quick look at. And then just finally, my top tips. I think there was, again, when we first started doing remote consultations, there was a thought that actually it would be a lot easier than face to face, but I think it can be quite draining. And quite often we're doing virtual clinics from 8 till 1. So I'd say remain nourished in terms of just making sure you've got a drink and a snack with you, because I find you don't get the kind of, if you're doing a face to face clinic, at least where I am, you'd sort of leave your room, have a quick chat, go back in, take your next patient. It's not so it's not like that for us, at least with virtual consultations. I find we work on multiple systems, so if I'm doing a virtual consultation, I've often got 4 applications open at one time, and I'm switching between the two. And in the early days, I found if I had my email open, I'd often get sort of beeps from my email, and there's a temptation to check the emails that have come in. So I now make sure that everything else is closed down except for the applications I need open. We do safeguard our consultations, so in terms of making sure that if we talk to patients that they're in a suitable place. So if they're in the supermarket shopping queue, I suggest that we call them back another time, and also making sure that they're happy to talk to us as well. I've already mentioned making sure that during your consultation that you're able to represent patients who perhaps are not suitable for virtual clinics, and then also just confirming the mode of documentation. So we use we enter all of our records onto our electronic patient record, but we clearly mark that it is a virtual consultation, and then just make sure that we end the consultation by informing the patient that they will receive a letter as normal, and if we want them to take a blood test, how to go about it, i.e. that we would like them to call the GP. And I'd just like to say thanks to Dr. Richard Wolfe and our Care Redesign team. Dr. Wolfe allowed me to use a couple of his slides tonight, so big thanks to him, and also to the Severe Psoriasis Service, who I work with. Thank you.
Fantastic. Thank you, Lucy. That was really informative. I've certainly learned a lot through that presentation. So clearly a challenging time, but it's had to be a very adaptive service during I guess the past 10 months, hasn't it?
Absolutely. Yes, yeah. And continues to be as well. I think that's the other important,
Yes, absolutely. So thank you so much for all the audience. I know there's lots of you watching. Please do like, subscribe to our channel. I'm going to try and take this opportunity to maybe ask 1 or 2 questions, but please, if the audience does have any, fire away, and I will try and put it forward to both Lucy and Julie. I guess one of the things I wanted to ask Lucy was how many patients, or the proportion of patients, didn't actually succeed very well with the app?
So that's something we're still collecting data on the moment. We think it's quite low, so we think it's around sort of about 20%. So they are, and it's for different reasons. Some people, we have recorded their phone number incorrectly, so there's something on our computer system whereby if we've put a space in the phone number, they won't get the message. And the same again if we don't have their mobile number listed as the first number. But that's something what we're trying to do now. Every clinic, if somebody hasn't answered the questionnaire, then we ask them the reason why and record it and feed it back to the data team, especially at the moment, because for instance tomorrow we're planning on sending out a message on this portal giving very basic advice on the COVID vaccine as well. So again, that's information that we really want to get to as many people as possible. So it is important for us to know that we are reaching everybody.
Yeah, and just I'm conscious of time as well, but last question for yourself, Lucy. How do you approach services to respond to vulnerable patients? Let's say, for example, the elderly or those with learning disabilities. How do we get the assessment done?
Yeah, I mean, I think it's hard, and I don't think at the moment I'm succeeding with everyone. We do have a nurse-led day centre in my hospital, and what I have done with some patients who perhaps don't want to be phoned, or it's not possible to be phoned, and would only come along in the afternoon, then I've been seeing them in our day centre and speaking to our consultant as to a plan of care with them. So I think it's trying to be flexible, but I do think consistency. So I think within our team we have 11 clinical nurse specialists when everyone's working in our department. But I think it's helpful if the same person is phoning the patient. So I have another patient this week who has, we're trying to get him for a CT scan, and he has decided he doesn't want to attend, but I'm actually going to call him on a weekly basis so that I can follow up and see if we can come to an arrangement whereby he does want to attend, because I think sometimes if different people are calling in those situations, the message gets muddled, and I do think sort of consistency is the key.
Yeah, no, great. And I guess the premise of do more, not less in those groups.
Definitely. Yes, absolutely. Yeah.
Great. So I know Julia's been patiently waiting for her presentation. So I will do the introductions, but thank you again, Julia, for agreeing to talk about cutaneous manifestations. It's a very much a dynamic topic, but a little bit about Julia herself. She's worked as a dermatology nurse for a number of years. She graduated from Hertfordshire University in 2018 with an MSc in dermatology skills. She's also a lead dermatology outreach nurse working in secondary care, and in terms of does have a very prominent educational development nurse position for the British Dermatological Nursing Group. And this is, as I referred to previously, it's a charitable organisation, isn't it, in terms of promoting the care of patients with skin disease, and it's got a thriving population of nurses. So over to you, Julia.
Well, thank you very much. Yeah, we're going to look at cutaneous manifestations of COVID. I hope that this presentation will remind healthcare professionals and the public that rashes are increasingly acknowledged as a possible diagnostic sign of this skin disease, of this disease, and they can be used to prompt self-isolation and infection prevention measures. So, okay. We're going to consider the clinical features of COVID-19 eruptions, and we will look at their timing and evolution in relation to the more widely recognised symptoms of temperature, cough, and loss of smell and taste. And then we're going to consider what types of rash should alert us to self-isolate. And then to finish with, I want us to briefly discuss some of the theories around the etiology, which are currently being debated, but obviously are not fully understood at this stage. So what's the evidence? I hope that you will all be familiar with the Zoe COVID symptom study, which is being led by the King's College Hospital. There's so far 4.5 million participants, just over that. And it's identified that 8.8% of people with a positive COVID swab experience a skin rash. So investigators have therefore proposed that rash should be a key diagnostic sign for detecting COVID-19 infection. So for 17% of people, rash was the first symptom, and for 21%, it was the only symptom. So from this data, I think we should be concerned that there are as many perhaps as 1 in 5 people with a rash who are unaware that they're infected with COVID. So there was a Spanish study published in the British Journal of Dermatology back in April 2020, and it proposed 5 classifications for cutaneous eruptions associated with COVID-19 infection. I think it's important to remember that as a novel disease, this list should be dynamic, it is dynamic. It will change in the months ahead, perhaps. For most of these patterns, we will see that they're generally self-limiting and typically resolve in about 7 to 10 days. So look, we'll start with the first one, which is classified as a pseudo-chilblain, and that affects about 12.5% of people. They are sometimes referred to as acral erythema or COVID fingers and toes. They may also develop on the edge of ears. Pain is identified more as a feature than rash, than itch, sorry. And they're associated with mild cases of infection and are most common in asymptomatic people, young people typically, or children. So unfortunately, they do develop late in the course of the disease, so they're not a helpful indicator for self-isolation. And if there's no specific treatment, they will resolve over a few weeks. Sometimes people suggest using emollients with luramacrogols in, which are antipyretic, and sometimes 2% menthol may offer some relief. Of course, they can be purchased over the counter. So let's have a look at some images of the pseudo-chilblain. It is not typically located, chilblains wouldn't typically be located on the heel. So this is an atypical site. You could also see them, as I said, on the ear. But here you can see an image of the great toe here. It looks a little bit vesicular and quite painful. We'll have a look at the next slide, which again shows some vesicles. It looks quite bumpy and sore, and the image of the finger there, it's very raised and sort of inflammatory around the top of the nail bed. And now moving on to vesicular eruptions. These are sometimes classified as pseudovesicular eruptions, and they account for around about 18.8% of COVID rashes. So they have an atypical appearance to a vesicular eruption. They are associated with infections of mild to intermediate severity. So vesicles are small, raised, fluid-filled lesions or small blisters, which are about less than 5 millimeters in diameter. And this vesicular pattern associated with COVID may appear similar to chickenpox, and it may be localized and monomorphic. So this means that vesicles are the only type of lesion to manifest. And they may be found on the dorsum of the hands and feet, or over the elbows and knees, or in the submammary area of the trunk. However, just to complicate things, they do also occur in a polymorphic fashion. And in this case, you might see not just vesicles, but papules and pustules as well. In this case, they do tend to be more widespread on the trunk. So importantly, vesicular eruptions are associated with the early phase of COVID-19 infection, so before the development of other symptoms. So they can be a useful indicator for self-isolation. So let's look at some of the images. Here we've got a child with some scattered papules and excoriated vesicles on the face. And they're quite difficult to define on the image of the trunk. They're widely scattered, perhaps not very impressive looking, particularly on an image. When examining the skin, it is really helpful to touch it, to feel elevated lesions, and to look carefully at the contents of each of those lesions. See, is it a solid papule or is it fluid-filled vesicle? But obviously pustules are much more easy to define. We'll have a look now at another vesicular eruption. This is looking a little bit more extensive on the arm, and the image to the side of that is crusting and hemorrhagic, and it looks likely that it's in the resolution phase. Next, I can see some more vesicular eruptions here, and I think this sort of illustrates really why they're sometimes known as pseudo-vesicular, because they just look a bit unusual, not a typical appearance. So we've got a few scattered on the lower leg here, and then much more increased in size on the body and hemorrhagic looking. So quite sinister looking, really. We'll have a look now at urticarial eruptions, and these account for around 13.2% of cutaneous manifestations. So this pattern is quite significant because, again, it is commonly associated with early, symptom onset. Urticaria is therefore considered as a diagnostic sign for COVID infection. You may be familiar with urticarial eruptions. They're very common. We will have all had them, I'm sure, at some point in our life. Small, itchy red bumps which come and go quickly over a few hours. Changing location. Typically, they're very itchy, particularly intensely itchy on the palms and the soles, but they usually resolve and clear for most people fairly well and quite quickly, but they can drag on for weeks at a time for a small number of people. Urticaria, of course, is associated with angioedema, so you might get some associated swelling around the mouth or around the eyes, but this is rare apparently with COVID. So let's look at some urticarial eruptions. You may recognise them. Some red raised bumps, some with a blanched centre, and you usually see the surrounding flare. When it's extending in, large surface areas of the skin, it can be really uncomfortable. It looks itchy, doesn't it? I think, and it causes a lot of distress for patients when they're going through it. Next, I want to show you some symmetrical patterns of urticaria here on the elbows. Not quite as impressive looking, but still very itchy for the patient. So moving on now to morbilliform rashes. This is the most common pattern of the COVID rash. A systematic review identified that they account for around about 30.6% of all the cutaneous signs. It isn't a helpful diagnostic indicator because it develops simultaneously with systemic symptoms, and it's usually associated with adults and more severe cases of disease. So morbilliform rashes are typically associated with viral infections, They are often widespread, and a variety of lesions might be present. So you'll see macules, which are flat, papules, which are raised, and then possibly some purpura as well, which are non-blanching. So you might as well see some confluent areas of erythema, so quite extensive. The patient can, of course, feel very uncomfortable with all of this going on, and symptoms of itch and burning are commonly described. So I think when patients present with a morbilliform rash in the early phases, they will resolve. They are self-limiting, but with symptoms, it's sometimes kind for the patient to have topical steroids, and I'd suggest potent strength topical steroids. Emollients can also provide some relief. So let's look at some of the morbilliform rashes. Here we've got some maculopapular images. One doesn't look quite so impressive as the other. And I think as well, it's important to remember that erythema is really striking on Caucasian skin. It's less visible on darker skin tones. And so when you are assessing skin, you need to use all of your senses, touch the skin and look carefully to identify the intensity of the symptoms. Also as well, look in mucosal areas, because these sites can also get uncomfortable. And we can see that some studies have identified lesions in the mouth. They may occur in isolation or in addition to morbilliform eruptions. Keeping in the same pattern of a morbilliform eruption, we're now going to look at erythema multiforme like patterns. This particular pattern is, so morbilliform patterns may include rashes with some atypical features. Yeah, and so this rash has lots of confluent erythema, but if you look really closely, that you can see some targetoid areas. So purplish center, dark purple centers with a slightly lighter pink ring around the edges. It's usually quite distinctive and quite impressive as well to look at. So target lesions are associated with erythema multiforme, which is activated by a virus, which is typically the herpes simplex or cold sore virus. And targetoid rashes may also be associated with drug eruptions. We'll move on to purpuric rashes, again, coming under the heading of morbilliform eruptions. They can come in a sort of punctiform distribution, or they can cover larger surface areas. So in these images, we have scattered purpura on the lower leg and a more confluent non-blanching purpuric rash, which is focused around the axilla. So purpura develop following a vasculitis. So you've got microvascular damage and leakage of blood into the skin. They are easy to recognize as they do not blanch when you put pressure over the area. They remain that same intense dark color. They can be quite tender to touch, and they can also become palpable, raised above the surface of the skin. So they do cause some concern, and they do need to be monitored, in case they extend or become areas of necrosis. So incidentally, vasculitis can also be caused by either drugs and some types of infection. Okay, so as part of these morbilliform rashes, we see some patients presenting with other similar conditions, dermatological conditions or drug eruptions. So I mentioned it earlier on about vesicular rashes that can look surprisingly like chickenpox. But here as well with morbilliform rashes, their distribution can also appear in the form of pityriasis rosea or perifollicular eruptions, etc., the pseudovesicular and erythema elevatum dirtinum purpuric type eruptions. Okay, so which I think is quite interesting, and we'll look at that why a bit later. So finally, looking at livedoid and necrotic lesions. So these are associated more with severe disease, and they account for around about 9% of all the cutaneous signs associated with COVID. And this group of rash is generally seen in hospitalized patients. Therefore, they're not helpful for diagnosing. Livedo, it refers to mottling of the skin, and it's caused by underlying vascular changes. And livedo is more likely to be localized with the trunk and the acral areas of the body most commonly affected. So they do cause itch, pain and burning sensation, and they can vary a lot in their extent. For sometimes in children, they're seen in less severe disease and they can be transient. So we'll look at an example of livedo just to help you recognize it. Should you see it, you'll see, of course, it's just a mottled appearance. It's flat to the surface of the skin. You shouldn't feel anything when you touch it. So this patient actually had confirmed a suspected COVID, not confirmed. Yeah, it's not always seen in hospitalized patients. So we'll look at more severe mottling in this image. We've got flat purpuric areas, darker discoloration, which causes greater concern. I'd not expect this type of rash to present in general practice. It would be in the hospitalized and very poorly patient. And now sort of we can see some necrosis in these images here. Occlusion in the microcirculation causes necrosis, and of course it is really very painful for patients. So looking again now at the severity spectrum of COVID, we know that it is quite wide and it varies through the population. So cutaneous symptoms can occur at all stages of the disease process, and this diagram helps to illustrate how cutaneous symptoms are most commonly associated with the different levels of severity. Chilblains obviously being less severe spectrum, and the livedoid patterns at the upper end of the disease spectrum typically. Quickly touching on the etiology, there's a lot of speculation at the moment about etiology of these cutaneous signs. Patients in hospital may well have received medication prior to the onset of their rash, and this could arguably cause some of the morbilliform eruptions that are being presented, and also the erythema multiforme type eruptions. And we know that hospitalized COVID patients will receive anticoagulants, and they may also be attributed to hemorrhagic eruptions. And it has also been suggested that vascular dysfunction may be a specific feature of COVID-19. Of interest is the theory that COVID is responsible for the reactivation of a previous skin manifestation. And this was identified in a letter published in the British Journal of Dermatology just this month, actually. Yeah, and so Psoriasis rosea and herpes virus, you know, are examples of this kind of thing. So erythema multiforme, again, being associated with the herpes virus. So that's the question, are some of these rashes presenting because of reactivation of other viruses caused by COVID? So summarising really, this is a novel virus. There is a lot to learn about this new disease. It's wise for patients and healthcare professionals to consider any unusual or unexpected skin eruptions as a possible early sign of COVID. Encourage self-isolation for urticarial and vesicular eruptions, and report and document possible manifestations to increase our understanding. Just have a few references if you wanted to do a little bit more reading on this subject. In particular, you'll see here that I've identified the British Association of Dermatologists, who published an online directory of images, which is freely accessible. And if you're listening on the radio, then you know that you could use that to take a look at some of the images we've been talking about this evening. Okay, so we'll go on now to look at personal protective equipment and the skin damage that is caused. I'm going to cover this quite quickly because of time.
Yeah, I was just going to say, Julia, maybe about 5 minutes.
Yeah. Okay.
Perfect, thank you.
Yeah, okay. I'll just zip through. Let's get straight to the picture here of this poor nurse. And this is an image published in the Nursing Standard. And it just illustrates really the extent of possible skin damage that people are facing. Obviously, we've got bruising, we've got breaks in the skin, and this is all caused by pressure and moisture building up under face masks. And I think it demonstrates really the commitment of nurses really and doctors working in the conditions that they're facing at the moment. Some of the cutaneous risks and the side effects of PPE, as I say, they're kind of being identified as pressure, irritant contact dermatitis, allergic contact dermatitis, urticaria, people saying about flares in acne and rosacea, and warm, moist environments obviously promote skin infection. So I look at a quick overview quickly of some of the tips that health professionals can take to sort of minimize the risks. Obviously, in an ideal world, we'll be limiting the length of time that we wear this PPE. Obviously, that's difficult under the circumstances, but suggestions are that 1 to 2 hours are, what the max that we should be wearing things for. It's really important that all of our masks are fitted carefully and not too tightly secured, as long as they fit snugly to the face. And using liquid barrier products can be a really helpful way of protecting the skin under a face mask. I recommend that people use that. Things like Cavalon and Derma S are products that can be quite helpful, and they come in with a little applicator that you can use around the area. Once it's dried, then put the PPE on. For any breaks or potential blisters that are forming, thin protective dressings can be used, but of course they cannot be used around the mask area because obviously that would constrict the fit of the mask over the face. So only for the bridge of the nose and other areas. Emollients and mild to moderate topical steroids are suitable for inflammation in areas on the face, but they must be avoided on people with acne. So don't put topical steroid on any suspected acne flare. Just to let you know that 99% of PPE damage is caused by gloves, repeated hand washing and the use of hand sanitizer and temperature changes. So got to avoid latex gloves. Never in a healthcare setting would you use them. It's always nitrile and vinyl gloves. They've got to be changed frequently. One layer if possible for that cooler, a less sweaty kind of environment for your hand. Avoid wet work at home. Wear gloves outside and always use loads of hand cream. Have hand cream accessible at all the time through the day. This is the mantra that's being stated. Management: clean, protect, restore. So wash with soap and water, re-wash with an emollient, dry the skin carefully and apply emollients frequently. And a suggestion that you use cotton gloves at night with a very thick, greasy ointment. Really just want to stress the increased risk of infection when the skin integrity is broken. And also if you have sore skin, you're more likely to touch your face, touch your mask. And of course that does increase your risk of catching COVID. So it is something that we need to keep an eye on and to protect ourselves against. So just to summarise on that side of things, early intervention's key. Discomfort and poor skin integrity increases COVID. Always refer yourself to Occy Health if you have a problem. Just to say thanks for the slides to DermNet NZ, and they're the references if you wanted to look at them.
Fantastic. Thank you, Julia. You had about 30 seconds to spare, so that was
Sorry
perfect.
about that, overrunning.
Oh no, that was great. So yes, I'm gonna come. So we have been getting a few questions through. So I'm gonna try and pose them to Julia, and then perhaps Lucy can join with some of the wider discussion. I guess with regards to PPE, Julia, the recommendation is to take it off after a couple of hours, or change and look after your skin health. There's obviously some hesitation because it's someone working in the front line to be in a position where they have to frequently tamper with their PPE. There's some hesitancy there. So how do you approach that?
Absolutely. Donning and doffing of PPE is absolutely critical. You have got to learn how to do that properly. You'll be trained, should be trained in the hospital on how to do that and the order in which you do it. I never touch my face mask unless I've actually got alcohol hand gel to hand, or I've washed my hands. I just don't. I'm absolutely scrupulous. I've never touched my face or my mask without cleaning my hands first. That's really critical.
Yeah, no, good nuggets of information there. And I guess the other thing is there's lots of detail about the cutaneous manifestations, but is there any evidence to say that someone with pre-existing dermatological problems are actually suffering a great deal because of COVID?
From the cutaneous damage, from the PPE damage?
PPE, well, just COVID. We're talking about.
Yeah, I'm not quite sure. I suspect that could be the case, and certainly, if there is this association with reactivation of other, skin signs, then I think it is possible, really, that people with skin disease might be less resilient, really, to developing things. So potentially, I think, unfortunately, for people with skin conditions, they may be slightly more likely to have skin changes as a result of infection.
If I was to just say, in terms of first psoriasis patients, when the pandemic first started, there was concerns that people on immunosuppressants might be at more risk of complications with COVID. But definitely the data from SoProtect, so that's the one I'm most familiar with, doesn't show any worrying signs at all, and actually makes us quite confident that people on systemic immunosuppressants are not at increased risk of complications from COVID infections. I think where we are actually, our dermatology doctors have said it was mostly them actually when they were in the ITU or in the ward saying, "Oh, look, this patient has this rash, etc." Rather than patients at that stage, obviously because they're in hospital at that stage, rather than patients complaining of cutaneous manifestations.
Yeah. Thank you. Lucy, if I come to you, if we're using the app to send images, and there's probably a huge number of healthcare professionals as well as patients and relatives kind of listening in and tuning in, what angles do you need to take in terms of the images? And I guess also, how do you address the issue of amelanotic cancer, for example? Can apps address that area?
Yeah. So there are various platforms with increasing levels of complexity that can help with diagnosing different types of skin cancer. We don't actually use them in our hospital, but I do know that there are other hospitals whereby they triage skin lesions on the basis of different computerized platforms and cameras basically built with dermatoscopes in with it. In terms of, for us, it would depend on whether I'm photographing a wound, in which case it might be necessary that I include measurements, or whether it's just because I want to show worsening psoriasis. I think it's very much on a case-by-case basis. I think patients can be quite rightly quite alarmed if I whip out my mobile phone and say I'm just going to take a few photographs. So again, something that I do is I always have a paper photography consent form so that the patient can complete it. And I explained to them that it's an app on my phone. The picture is going to be sent to my email address, and then it's not going to remain on my phone as well. So I think it's just talking through, and if there's any hesitation or the patient is in any way concerned, then I either don't take the photograph or would arrange them to attend our medical photography department as well.
Yeah, great, thank you. Julie, if I come to you, how do you address the issue of dry skin? I know you kind of briefly touched on it, but which creams or which products do you specifically recommend? Because, well, it's clear to say my hands are all very much crackled.
I think it's important for the patient to choose one that they like. However, it's really lotions for the day, nice thin products that are easily absorbed into the skin while you're at work. Creams as well are quite useful if you've got a little bit longer, and they're longer lasting. But the thick, greasy ointments are much better for effective and longer hydration. So there isn't a hard and fast rule about which is better. There are some that have different ingredients which can draw water into the skin, products with humectants. And so, for really severely dry skin, sometimes, having additional ingredients. There's such a huge range of emollients available. It's really difficult to, to sort of give you my favorite or anything. But I just go for the consistency, the cosmetic feel, and the one that you like. Unperfumed. It's got to be unperfumed with as minimal ingredients as possible, really. So ointments have less ingredients and are much safer if you've got any concerns with preservative allergies. So keep it bland. That's what we would always say.
Great. And Lucy, I guess in terms of 2021, what's your hope for how dermatology should function? Because I guess there's lots of recommendations that have been present for a number of years, but obviously COVID-19 has really catapulted lots of these forward.
Yeah, I think it's really getting over the next couple of weeks and seeing how the landscape is, and it is whether we are going to have a plan for the future whereby we're going to have times whereby we have to do what we're doing now and basically switch to virtual and manage patients like that. But I think it's just working out that whatever we're doing, that we're kind of keeping patients safe and on treatment as well. And then I think for me as well, it would be nice to kind of work out a way to review patients pragmatically, i.e. if a lot of our patients are under gastro or respiratory, and I think, is there a way that a patient can attend a hospital once a year and see everybody at that one time? And is there a way that perhaps we can move dermatology out to the community, which again is something we were thinking of before, but, joining up care, I guess, more and more.
Yeah. And Julia, just to get a further understanding about the cutaneous manifestation, how should the healthcare professionals and the general public engage with trying to develop the directory of what we know about COVID?
Well, I think using the British Association of Dermatologists information is really key. There's lots of educational resources that they provide, and it is difficult assessing the skin. I think it's just important to ensure that you've got that open. You're tuned into the fact of the vesicular and the urticarial type eruptions being the possible diagnostic ones. It takes time to be able to be proficient in identifying rashes, and I think there's so much to learn. I don't know if that's helpful, but the British Association of Dermatologists would have most of the resources available to support healthcare professionals to become more knowledgeable in this area.
I was going to say as well, on the British Association of Dermatologists website, the AAD, so the American Academy of Dermatology, they have a registry whereby they're collecting data on cutaneous manifestations of COVID as well. So if you do ever, again, come across a patient, it's always worth capturing the details for that registry too.
I was looking at that. I think there's about 40 plus countries have been involved with that registry. So it's Yes, it's a huge cohort, but only time will tell what that means. But it's great to have you on board discussing this. This is just from one of our viewers who obviously finds the conversation very stimulating and something of interest. But again, I'm mindful of time, but I just wanted to thank both yourself, Lucy, and Julia for sharing your Tuesday evening talking about dermatology. I'm sure it's very prominent in your life anyway, but just sharing that valuable time is very much appreciated.
That's okay.
Thank you.
Yeah.
Thank you. And yeah, just for our audience, we have other topics coming up. We are looking at long COVID and what that means in the future, and also the new Mental Health Act and the reforms with the white paper being recently published. So lots of things to review and consider. But again, from MEDtalkx, thank you again for tuning in.